ESG, Gastroenterology and Nutrition Group. And we know that this topic is relevant for all of us on this call who deal with children. I don't think there's anyone who's managed a child who has not dealt with abdominal pain. And today we have a great expert panel who will lead us through the discussion on chronic recurrent abdominal pain in children. And we're also fortunate to have a parent give us their perspective on their experience with this very common complaint and often very challenging complaint. So before I give us the outline and brief introduction for our first speaker, I'll invite one of our co-chairs for the subspecialty group. If Dr. Mamia Nyako is on the call, she can give us a few words, and also Dr. Fa. Thank you.
Hello, good afternoon, everyone. And thank you very much, Abna, for accepting to moderate this session. Like Abna said, for some of us, we are very excited that we are having to do this topic. I think over the years, we all know that one of the common reasons why children will be brought to hospital aside the cough and cold is abdominal pain. And for me personally, it's become very concerning that many times we go to town and do all sorts of things, probably without taking a very good history to know what we are dealing with. And personally, I'm a bit frustrated with seeing many people test for H. pylori every time a child has abdominal pain. So I think that this session is really going to give us clarity as to what to do when we see children with abdominal pain from home to the hospital. And I'm sure we'll all leave with new knowledge and new ways of doing things. So I want to thank the panelists as well for accepting to do this. And I'm sure we'll all have a fruitful time. Thank you very much. Abna, over to you.
Thank you, Dr. Nyako. I don't know if Dr. Fa has any words or we can proceed. Maybe we'll hear from her in the course of the chat. But Dr. Fa, if you have any words for us.
Good afternoon, ladies and gentlemen. At the moment, I'll just say thank you for everyone for coming. I know the presenters are going to do very good with this presentation. Just like Dr. Nyako said, it's a bother to every parent. That is why we brought on board a parent who has been through the nooks and crannies of having to deal with a child with abdominal pain. It has been a horror for him. Hence the reason why we added him to this call. Whatever I have to say, maybe the chunk of what I'm going to say will be after the presentation. So thank you very much, Dr. Abinatechi.
All right, thank you, Dr. Fa and Dr. Nyako. So I'll briefly go through the outline for our program, just so you have an idea of what is to come. So we'll begin with Dr. Nanama Ananibemfo, who will take us through the epidemiology, types, etiology, and clinical presentation of recurrent abdominal pain in children. And then Dr. Juliet Ankuma will lead us through investigations, diagnosis, and management. Then Dr. Tree will take us through the role of the pediatric surgeon, in chronic abdominal pain. And then finally, we will have Mr. Fred Sapon share with us his experience as a parent, looking at the psychosocial and economic impact on the family with a child who has recurrent abdominal pain. So without wasting much time, we want to dive right in. I'll ask Nanama to sort of begin sharing her slides whilst I introduce her. So Dr. Nanama Ananibemfo is a specialist pediatrician at the Department of Child Health, Kolebu Teaching Hospital. And she's a fellow in training with the Ghana College of Physicians and Surgeons, specializing in pediatric gastroenterology and nutrition. She had her undergraduate training in Kwame Nkrumah University of Science and Technology, and holds a Master of Public Health in Epidemiology and Disease Control from the University of Ghana. She's also a member of the Ghana College of Physicians and Surgeons. So Dr. Anani Bimfo has a strong interest in pediatric gastroenterology, hepatology, nutrition, quality improvement, and clinical research. So already what I've described, we know that we are in good hands. So Nanama, please set the ball rolling for us with your talk. Thank you very much. Nana, check if you are muted. Whilst we wait for Dr. Anani Bimfo, let's remember that in the course of the presentations and the webinar, evaluation and then CPD forms will be shared. So let's look out for these if they haven't already. Yeah, so that we can fill them accordingly. Thank you very much.
Hello. Please, can I be heard?
Hi, Dr.
Hi,
Nyako.
that's the issue. Okay. Thank you. Please, can you see my screen?
It's coming up, yeah. It's not yet in slideshow though.
Okay, let me just put it in slide mode. Okay. Please, is it in slide mode now?
Yes, please.
Okay, thank you very much, and apologies for the technical hitch. Okay, so thank you very much and welcome all on the call. So today we're going to start off looking at the epidemiology, the types, etiology, and the clinical presentation of chronic abdominal pain. And I titled my presentation, Thinking Outside the Box. As we go through, I want us to appreciate why it's important as clinicians, healthcare professionals to always think outside the box when it comes to children with chronic abdominal pain. So these are the objectives of my presentation. I hope that at the end, we should be able to define what chronic abdominal pain in children is. We should describe the epidemiology and then the burden of this condition in children, and then classify the causes into organic and functional disorders. Then we should be able to discuss some of the common causes and describe the clinical patterns and red flags of chronic abdominal pain in children. And this will be the outline of my presentation. So we'll go through a bit of introduction, then we'll look at the epidemiology and classification, then clinical assessment of a child with chronic abdominal pain. And then finally, we'll just look at some of the common diagnoses that pertain to us in Ghana. So I'll start off with a case presentation. This is a 9-year-old child who we saw in clinic. Her name is not Mary, but I use this for the sake of the presentation. And she presented with a 1-year history of recurrent abdominal pain. Mary described the pain as dull, cramping, and located at the periumbilical region, and graded the pain between 8 to 9 out of 10. This pain limited activity, and because of that, Mary had been away from school for the last 2 terms, but the pain didn't wake her up from bed. The pain was also occasionally associated with headaches and vomiting. She came into our clinic in Kolebu with a worried mother. They had been to several hospitals and had carried out a ton of lab investigations, including one upper GI endoscopy, and all the labs they had done were normal. And Mary had been treated for H. pylori infection 3 times, but the pain still persists. And the mother was so worried, and the question she asked us was that, "Doctor, what is wrong with my daughter?" We see children with chronic abdominal pain day in and day out in our clinics, on our wards, and even at home. Some of us have had personal experiences with our children or relatives who have had chronic abdominal pain. And it's such a difficult condition to manage. And if you don't have the necessary knowledge and skills, it can be very difficult when it comes to navigating through the clinical processes and pathways. So for introduction, abdominal pain is one of the most common symptoms that a child will present with. When the child is eating and doesn't want to eat, the child will say, "My tummy is hurting." We hear it day in and day out in our homes and in the clinic. For younger children, it's actually the commonest type of pain. And when you take older children and adolescents, it's the second most common type of pain after headaches. And when it comes to managing children with chronic abdominal pain, it's very difficult because of the different ways they present with and the non-specificity of their symptoms. So it requires careful evaluation to identify red flags and avoid missing the diagnosis in many of the children that we see. So when it comes to the definition of chronic abdominal pain, it has evolved over the years. So in 1958, Apley and Nash came up with a diagnosis where of recurrent abdominal pain, and they defined it as having at least 3 episodes of abdominal pain of at least 3 months duration, and that these episodes were so severe that it affected the daily activity of the affected patient. And over the years, there's been guidelines from Europe and North America, and they have churned or come up with a more contemporary term now, chronic abdominal pain. And this refers to persistent or recurrent abdominal pain that lasts 2 months or more. So now with the definition, we don't really look at the number of episodes of pain that you've had. But once the pain is persisting and is being more than 2 months, you can confirm chronic abdominal pain in your patient. And with this condition, it encompasses both organic and functional causes. And when it comes to assessing children with chronic abdominal pain, the goal is that you need to identify the underlying cause rather than just simply describing the pattern of the pain. And it's very important that we actually look for the underlying cause and manage accordingly. So why should we even talk about chronic abdominal pain in children after all? We should remember that in the case of Mary and many other children that we see in our clinics, chronic abdominal pain affects their daily activities and well-being. We've had patients in our clinic who have been away from school for more than 1 year just because of chronic abdominal pain. And it affects them. A child is supposed to play, learn, and have fun. So if there's anything which is limiting the child from doing all these things, then it's a bother and it's something that we have to talk about. As I mentioned, it leads to long absences from school. And in the case of Mary, she had been away from school for a long time. And it's a major source of worry for the child and the parents especially. And for us clinicians, it can also be very difficult because if you have a child, as clinicians, our role is to be able to find what is wrong with the patient and then manage it. So if we are not getting on top of it, it's quite difficult and it's quite a worry for us. And it leads to recurrent or repeated consultations where patients and the children will move from hospital to hospital, just trying to look for answers. And there are the cost implication because there are several lab investigations that will be requested, many high-level tests and all that. And we see these children every day in our practice. So it's something that we have to talk about so that we get the right knowledge and skills to help our patients. So let's look at the epidemiology. Chronic abdominal pain affects about 10 to 20% of school-age children globally. And out of this number, 21% is so severe that it affects their activity. And the peak age is usually between 6 to 12 years, although you can see patients at the extremes of this age group. There's a slightly higher female predominance, but up to age 9, usually the male to or the sex ratio is about the same. And then from age 9 to 12, you have about a 2:1 male to female to male ratio. And majority of the causes of chronic abdominal pain do not have an identifiable organic cause, and it's almost about 95%. But unfortunately, in Africa and other low and middle income countries, the data still remains limited. So now let's look at the Pediatric Gastroenterology Clinic in Kolebu. This data was collected from 2022 to 2025. Chronic abdominal pain accounted for up to 47% of clinic visits within this period. And there was a slightly higher female predominance. We saw about a 1.6 to 1 female to male ratio. And about 91% of the patients we saw had functional abdominal pain disorders with a mean age of about 7 years. So it's something that we see every day in our clinics, and we really need to address and talk about it. So now let's talk about the different types of chronic abdominal pain in children. We have two main classification. We have the organic and the functional causes of chronic abdominal pain. So with the organic causes or the organic disorders, usually the pain is due to a structural or an inflammatory process or an infective process. So with this, you will see some form of tissue injury, inflammation, some infectious process, or abnormal organ function. And it accounts for just 10% of the causes of chronic abdominal pain in children. And with these conditions, you would usually identify either a red flag sign or symptom in the patients that we see. Whereas for functional abdominal pain, the pain is not usually explained by an identifiable structural disease. But now the preferred term that we want to use is disorders of gut-brain interaction. And as I said earlier, it accounts for up to 90% of the causes of chronic abdominal pain. And when you examine these children, when you take a detailed history, most of the time you do not really find any red flag signs or symptoms. So what are some of the differences if we look at these two types of chronic abdominal pain? When you look at the pain characteristic and the timing, for organic abdominal disorders, usually the pain is localized. So the child will tell you that it's more maybe at the right upper or the right lower quadrant of the abdomen. It can occur at any time of the day, and it usually wakes the child up from bed. Whereas for disorders of gut-brain interaction, the pain is diffuse, not really specific or localized, and it may have a variable location and would rarely wake the child up from sleep. For organic disorders, the onsets are usually acute or subacute, whereas for disorders of gut-brain interaction is gradual and insidious. As I mentioned earlier, you may see some red flag signs or red flag symptoms when you examine the child. And when you carry out laboratory investigations for organic disorders, you may find some abnormal findings based on what you are thinking of. Whereas for disorders of gut-brain interaction, most of the time, these are usually normal. There are several organic causes of chronic abdominal pain in children. And remember, the abdomen carries or holds a lot of organs. So for the GI tract, You can have inflammatory bowel disease where they'll present with chronic diarrhea and sometimes bloody stools and abdominal pain. You can have gastroesophageal reflux. When you look at the hepatobiliary system or the hepatobiliary tree, you can have hepatitis, cholelithiasis. Remember the genitourinary system, especially in females, you can have ovarian cyst, IBD, and then metabolic and hematological causes such as porphyria, sickle cell disease, where they can have abdominal VOC, and then DM as well. And then for the musculoskeletal, you should think of trauma, tumor, or an infective process to the vertebral column. So these are some of the things that we should think about when a child comes, and then we are able to better ask the questions and then examine them well to be able to identify some of these organic causes. As I said earlier, when it comes to managing children with chronic abdominal pain, it can pose as a challenge because, as I mentioned, they may have variable presentation. Their symptoms are not so specific. They're not able to describe how they are feeling in the abdomen. And sometimes, as clinicians, we treat the children as little adults. So sometimes most of the conditions that pertain to adults, we tend to give it to the patients that we see. And then the issue about over-investigation or under-investigation can also pose as a challenge. And the limited diagnostic yield, you keep on doing test upon test, and when they come out, they are negative, and you are really wondering what you are dealing with. Unfortunately, we still have a limited access to pediatric GI specialists, and we hope that as the years go by, the number is going to go up. And you have parental anxiety. As parents, our sole responsibility is to make sure our children are well and healthy. So if you're not getting answers, it causes anxiety and very increased expectations of the patient, of the parent, and it leads to differences in their health-seeking behaviors as well, or challenges with that. So now we see a child comes to us in the consulting room in the clinic with chronic abdominal pain. How do we begin the approach? How do we start managing these children? So first and foremost, when it comes to patients, we need to take a detailed clinical history. You need to find out about the onset of the pain. It's very important. Let the child localize the pain. So allow the child to lift her top up and then point to the specific area where she feels the pain the most. Let the child grade the pain, describe the pain as best as he or she can, and then also find about the duration of the symptoms. What time of day or night does the pain usually occur? And it's very important to find out whether the pain is related to food, defecation, or physical activity. Does it make it worse or does it help to improve the pain? It's always best to look at other associated symptoms. Look at the appetite of the child. Has it affected the diet? Is there early satiety? Does the child have any nausea or vomiting? Is there constipation? It's very important. And then you need to ask about diarrhea. You also need to take your time and do a systematic review because, as I said, we've looked at some of the organic causes, and some of them you may pick up some associated symptoms in the systemic review. So ask for weight loss, pubertal delay. Is there any unexplained fever or rash or joint pain? These are very important because it will give you clues as to the organic disorder that you are dealing with. The medical and surgical history is also very important, as we've spoken about sickle cell disease, diabetes mellitus, and then any previous abdominal surgery, because you can have intestinal adhesions, which can also cause recurrent or chronic abdominal pain. The family history is very important. Is there anybody in the family, especially a third-degree relative, who also has chronic abdominal pain, peptic ulcer disease or H. pylori, or gastric CA, because that will give you a clue as to what you are going to investigate the child for. The nutritional history, the feeding or the eating habits of the child. Some children are picky eaters. They eat certain things they do not eat. You need to find out and get a very good nutritional history. Also find out about food allergies as well, and then drug allergies. And it's very important that the psychosocial history, we take our time and take a detailed psychosocial history for any child that we see with chronic abdominal pain. Do not let us ignore the psychosocial history, because as we go ahead, we'll understand why this is important. You need to find out about any recent stresses, change in school. Is there any bullying in school? I remember we had a patient who actually had chronic abdominal pain. And when we probed further, we found out that she had changed schools and she was being bullied by some friends in her new class, and she was very uncomfortable with school. So anytime it was time to go to school, she had very bad abdominal pain. Find out about the family dynamics. We've had patients who have come whose parents are having separation issues, and these are some stresses which can affect the child. And the only way the only way it will manifest is through chronic abdominal pain. So please, let's take our time and take a detailed psychosocial history when it comes to our children with chronic abdominal pain. Then we have to really take our time and examine these children. We need to make sure we assess the anthropometry, find out if there's any weight loss or faltering growth. We need to, these are for the symptoms. So these are the red flag symptoms that you need to be aware of. And you need to ask these red flag symptoms to rule them out, to rule any organic cause. So please, if you forget anything in today's presentation, please do not forget this slide on the red flag symptoms. Is the child losing weight, or is the child failing to gain weight? Is there any form of gastrointestinal bleeding, any hematemesis or bleeding per rectum? Is there significant or persistent or bilous vomiting? It will give you a clue as to which organic disorder this child may have. It's also very important to ask about chronic diarrhea and nocturnal defecation, because remember, it is not normal for any child to wake up in the middle of the night to poop. So if the child is doing this, it's a red flag, and you need to investigate this child properly. Let the child, if the pain is localized, then it will point to your mind to one particular diagnosis or one organic cause. The family history is very important. And if the pain wakes up the child from sleep, then it's a red flag symptom that requires you to investigate this child. And then if there's any unexplained fever, rash, joint pain, or swelling, it should be a red flag symptom that you would further investigate this child for. So now when it comes to examination, you really need to take your time and look out for these red flag signs. This is also another important slide I want us to all take note of. Does the child have fever? Is the child ill looking, pale, jaundice? Then your mind is going to, let's say, hepatitis or any other chronic GI related disorder. Look for signs of malnutrition and wasting. Examine the mouth of the child. Make sure you are looking for any oral ulcers or any abnormality in the mouth, which can give you clues. Examine the skin from head to toe and make sure rule out any skin rash or any abnormality on the skin. Then you take your time and do a very good abdominal examination, looking out for signs of focal abdominal tenderness. And remember, when you are palpating the abdomen, you need to distract the child so that the child is not really aware. Explain the procedure to the child so that the child knows what you are going to do and may not be taken aback. Look for abdominal distension. If there is a red flag sign. And you always have to do a rectal examination. Inspect the perianal region, looking out for fissures and perianal tags. Do a digital rectal examination. You may have hard stool in the rectal ampulla, which may give you a clue to chronic constipation. Are there any abdominal masses or organomegaly? And then you look out for joint swelling or arthritis. So these are signs that once you pick one or two of these red flag signs, it means you need to go ahead to investigate this child for an organic cause. So now that we've been able to go through the clinical approach to seeing a child with chronic abdominal pain, let's look at some of the common organic causes of abdominal pain that we see in our children in Ghana. So we'll start off with the famous H. pylori infection. And I know we see this a lot. There are children who have been investigated for H. pylori. In the case of Mary, she had been investigated or treated 3 times for H. pylori, but the pain still persists. And this infection is usually acquired early in childhood, either through the fecal-oral or the oral route, and is usually acquired before the age of 5 years, and is highly prevalent in Africa. What I want us to take note of is that many children in Africa with H. pylori in the gastric mucosa are completely asymptomatic. There was a study that was done in 2017 by Ewuku Afa et al., and they found out, and was done in the rural parts of the Ashanti region, and they found out that they looked at the stool H. pylori antigen test for children in the area, and they found out that most of them, almost about 50% of them, had H. pylori in their stool, but they did not have any symptom of abdominal pain. So please let's take note that if you have a child who comes with only chronic abdominal pain, it does not indicate H. pylori infection. And the prevalence of peptic ulcer or significant GI pathology due to H. pylori infection is very low in children. About 5 to 10% of infected children will develop significant GI pathology. So it's important that we avoid repeated eradication without reassessing the diagnosis for these children to prevent the unnecessary use of antibiotics, which will lead to antibiotic resistance. And this is this poor bacteria with a funny grin telling us that is not always me. Now, another common label is chronic gastritis. I think in our clinic, most of the time when the referrals come, it's either chronic gastritis or acute gastritis that it's being used as a reason for referral. But we should remember that gastritis is a persistent inflammation of the gastric mucosa, and it is an endoscopic and histopathologic diagnosis. So you cannot make a clinical diagnosis of acute gastritis without doing an upper GI endoscopy or histology. Most of the time, these children may present with epigastric pain or discomfort. They may have nausea with or without vomiting, early satiety, and then occasionally they may have iron deficiency anemia. Usually, upper GI bleeding is uncommon, but it may occur if they develop significant upper GI pathology. So I want us to take note that if a child comes with only epigastric pain or without any red flag sign or symptom, it does not confirm acute gastritis or chronic gastritis. We need to look for other causes of the pain that the child may have and not just gastritis for these children. And always look out for the red flag signs and symptoms. Another common one, organic disorder, is allergic enteropathy. And this is a delayed non-IgE mediated food allergy, which usually affects the small intestines, but it can affect any part of the GI tract all the way from the esophagus way down to the rectum. And is usually triggered by cow milk proteins, gluten, and a host of other food allergens. And with this, the children will present with chronic abdominal pain. They may have chronic diarrhea. These are the red flag signs and symptoms which we are discussing here. Blood and mucus in the stool, they may fail to thrive. And it's usually common in infants and young children. But if the diagnosis is missed, it may persist into the school age period if it hasn't been found and then treated. And this prevalence is about 2 to 5% among children. And we should remember that if we do not make this diagnosis, it may predispose the child to develop disorders of gut-brain interaction later on in life due to gut hypersensitivity. And then another common mimic when we do our abdominal ultrasound is mesenteric adenitis. Just like how a child would have an upper respiratory tract infection and then gets some cervical lymph nodes being enlarged, it's similar to what happens in the intestine. So the mesentery has several lymph nodes that when a child has an upper respiratory tract or a diarrheal infection, usually viral, they may be inflamed and they may enlarge. And most of the time, they may present with abdominal pain, which is often localized. Fever may persist. And when you ask about a recent history of flu or diarrheal disease, it may be positive. This is usually a clinical diagnosis and it's usually self-limiting. Within a few days, the child is fine. So if the child is having persistent abdominal pain, after you've made a diagnosis of mesenteric adenitis, then it means you need to take your time and look for possible red flag signs and symptoms and investigate the child more. Okay, so now we look at the other side of chronic abdominal pain, which is disorders of gut-brain interaction. And if you know my bestie, we will realize that this is actually a very interesting relationship that we have. And remember, the brain and the intestines are related, and sometimes they may have some disagreements, and this leads to what we call disorders of gut-brain interaction. So it's a group of disorders which is usually characterized by chronic or recurrent GI symptoms. And with this, there's no structural disease which is present, which can readily explain the symptom. It was previously called functional gastrointestinal disorders, but this term has now changed because this old term was a bit non-specific and it was a bit stigmatizing because they felt that if it's not organic, then it means whatever is happening is coming from your head, and the stigma attached to it was not good. So now the new preferred term that we want to use is disorders of gut-brain interaction, and it can affect any part of the GI tract, from the esophagus all the way down to the rectum. And it's now defined as a symptom-based diagnostic criteria. Previously, it was more of a diagnosis of exclusion. So it's when you investigate the child and you realize that there's no organic cause. Then you say, oh, mommy or daddy, it's very likely your child may have a functional gastrointestinal disorder. But now, according to the Rome 5 criteria, it is a symptom-based diagnostic criteria. So you just look at the clinical symptoms the child is presenting with, see which of it best fits, and then you can make a diagnosis of disorders of gut-brain interaction. So there's a paradox. Remember, I mentioned that the prevalence, or it's causing about 90% of chronic abdominal pain in children, but unfortunately, it's very under-recognized, and there's a big mismatch between its prevalence and the clinical burden, because unfortunately, it's poorly represented in medical school and postgraduate training. I think that most of us, I don't think we even had functional abdominal pain or functional disorders being discussed when we were in medical school. And because of that, it receives limited attention in clinical practice. And that is why we always keep on looking for organic causes, but we should always remember that disorders of gut-brain interaction exist and they are real. And if we are able to early diagnose patients with these disorders, then it improves diagnostic confidence, it reduces unnecessary investigation, and it supports evidence-based medicine that we are always preaching and talking about. So it's something that we need to be aware of it so that we can make the right diagnosis in our patient. So I know there may be some Arsenal fans on the call who are used to this slogan, they never walk alone. And this is the microbiota gut-brain axis. And this is, I just titled this, The Gut Never Talks Alone. So remember, the GI tract is one of the organ that has its own nervous system, which is the enteric nervous system. And this enteric nervous system is always in constant communication with the brain or the central nervous system. And it's a bi-directional communication through the vagus nerve. So the vagus nerves and other nerves will carry information from the intestines to the brain for the brain to process it. And then you get feedback back to the intestines. Apart from this communication, you also have the microbiota. So the bacteria or the normal flora in the intestines, which may produce neurotransmitters or chemicals, which also communicate with the brain, either through the hypothalamic pituitary axis or through the immune pathway. So this is how these three structures or these three organs relate to each other, and they're always in constant communication. So when there's a problem with one part of this axis, then it affects the whole system of communication between the intestines and the brain. And we should remember that the intestines, the main role of the intestine is to digest, and then peristalsis for food to move through the intestines and be excreted or defecated. So when there's a problem in this axis, then it affects how the intestines or how the gut is going to function. Now let's look at the pathophysiology of disorders of gut-brain interaction. I want us to start off with the genetic predisposition. Most people, they found out that from several studies that there may be a genetic predisposition, but there are several sensitizing medical and psychosocial factors which can affect the microbiota gut-brain axis. And most of the time, these factors actually affect the children during the infancy period. And as they grow older, the influence may reduce. And you realize from the arrows that the arrows actually reduce in thickness as the child grows older. And when you look at the medical factors, dysbiosis is one of them. So early use of antibiotics, when we are giving our infants or neonates antibiotics without a just cause, remember it's going to alter the gut flora and can lead to some of the vulnerability to the microbiota gut-brain axis, some inflammatory processes, either infections or allergies. And then when you have motility disorders, can affect this axis that we are talking about. Also, the psychosocial factors. So, if the child has gone through any early life trauma or pain, family stresses, parenting factors, even how parents, some parents may be enabling, even child abuse can also play a role on this axis. Depression, anxiety, stress, recent change in school, change in maybe moving from one town to another, and the coping styles, how the children cope with stress or how they cope with anxiety, and then social gain and secondary gains can also cause vulnerability of the microbiota gut-brain axis. And all these factors is interconnected. So once there's a problem with this axis, then it leads to some of these pathophysiological processes. So the viscera becomes hypersensitive, the intestines become hypersensitive. So instead, as soon as the child finishes eating or as the food moves through the intestines, it causes the intestines pick it up, and then the enteric nervous system will pick it up as an abnormality and then send it to the brain. And then when the brain also picks it up, because of this disorder, there's central hypervigilance and hypersensitivity. The brain would also process it in an abnormal way, and then the pain is amplified. So it's sort of like a cycle. The child is eating, feels the pain, it's sent to the brain processes it abnormally, then the pain is amplified, it comes back to the abdomen as exaggerated pain, and it goes on and on and on and on. And most of the time when I'm explaining this to parents, I tell them that just imagine you have a computer at home. Remember, if it's an organic cause, it's a hardware issue. So maybe the mouse screen or the mouse is not too sensitive, or you have some keys which are not functioning. That is a hardware problem. But for disorders of gut-brain interaction, it's a software problem. So maybe you have your screen glitching or the screen freezes once in a while. That is how disorders of gut-brain interaction is. So you explain it to them for them to understand that the child, structurally, there are no structural abnormalities. We are not saying that the pain does not exist. The pain exists, but it's just because of this interaction between the brain and the intestine. The brain and the intestines are actually perceiving the normal function of the GI tract as something that should cause pain, and that is how the child manifests in pain. So once you're able to explain the pathophysiology to the parents, then they're able to understand what the cause of their child's pain is, and then they are with you when it comes to managing and investigating this child. So please let's remember this slide when it comes to the pathophysiology. So there are different types of functional abdominal pain disorders or functional GI disorders. And in just May of this year, the Rome Society came up with a new criteria or guidelines. So this is a group of gastroenterologists that come together to develop guidelines when it comes to managing and investigating children with functional disorders. And these are ones which pertain to abdominal pain. So the ones I've highlighted in blue are the ones that we are going to talk about. Remember, I said it can occur all the way from the esophagus way down. So for the upper GI disorders, we have functional dyspepsia. For the lower GI disorders, we have irritable bowel syndrome and chronic constipation. Then we also have the centrally mediated abdominal pain disorders, which was formerly called functional abdominal pain, not otherwise specified. And then we have episodic abdominal pain disorders, which is abdominal migraine is one of the common examples. So we'll look at these ones briefly in the subsequent slides. So now let's look at functional dyspepsia. It is characterized by chronic dyspeptic symptoms without an identifiable structural or biochemical cause. So with functional dyspepsia, remember, it may be due to impaired gastric accommodation, impaired gastric emptying, and the visceral hypersensitivity that we spoke about just recently. And there are two main presentations of functional dyspepsia. We have the postprandial distress syndrome, where the pain is usually related to meals. So as soon as the child begins to eat, or as soon as the child is done eating, the child may begin to feel epigastric pain, has early satiety, and then post-meal fullness. And then we have the epigastric pain syndrome, of which most of our patients that we manage for chronic gastritis, acute gastritis, would have, because it's usually meal unrelated. They may have epigastric pain, burning sensation. But if you take your time and you identify, you are looking for red flag signs and symptoms, it's not present, you ask more, you take a detailed history, then you can make a diagnosis of epigastric pain syndrome in these children. And remember, it's a clinical diagnosis. And as I mentioned earlier, most of the children that we label as gastritis may have functional dyspepsia. Then let's look at irritable bowel syndrome. So this is abdominal pain with alteration in your bowel habits. So either you are having abdominal pain with diarrhea or abdominal pain with constipation. And with these ones, usually defecation actually helps the pain to get better. And the pathophysiology is what we've spoken about earlier, about the visceral hypersensitivity, the GIT microbiome changes. And as I mentioned, it is pain with altered stool pattern. And there are 4 main types. So you can have it related to constipation or diarrhea, or you can have the mixed picture where they may have alternating bouts of constipation and diarrhea. And then we have the unclassified type as well. But with irritable bowel syndrome, you always need to make sure you exclude red flag signs and symptoms, because inflammatory bowel disease is similar. But once you have a red flag sign or symptom, then you need to investigate the child for inflammatory bowel disease. Then the good old chronic constipation. It's characterized by difficult, infrequent, or painful defecation without an underlying structural or metabolic disorder. And when it comes to chronic constipation, the pathophysiology is a bit different. Remember, the child has pain when he's defecating, so would voluntarily withhold trying to defecate. So you see them going to hide in a corner, or they crisscross their legs, and you see them jumping up and down in a bid not to pass stool. So the stool continues to pile up and accumulate in the rectum. There's reabsorption of fluid. It increases in size and consistency. And now this hard stool is now more difficult to pass. And then the cycle keeps on going on and on and on. And this usually happens when there's a change in routine. So you are now potty training your child, or changes in diet, or a stressful event, starting school, and now you are used to pooing at home. Now you go to school, and then they just don't want to poo in school. And then when they postpone defecation because they are too busy playing or having fun, all these can cause chronic constipation. And most of the time when we are taking a history, we only ask the mother, does your child have constipation? And then the answer is usually no. But we need to ask about specific symptoms. And if you have a minimum of 2, then you can make a diagnosis of chronic constipation. Is there infrequent stooling, usually 3 or less in a week? Are the stools hard, painful to pass? Is the child straining? Are the stools large in caliber? So you need to show the parents or the child the Bristol stools chart. Let the child point to how the stools usually look like. And sometimes they may have fecal soiling or accidents where they may have some fecal matter in their panties or diapers. Usually it's involuntary, and it may give you a clue of chronic constipation. And as I mentioned, stool withholding behavior is also some of the things that they will present with. And it's the commonest cause of chronic abdominal pain when you take the disorders of gut-brain interaction. So please, let's ask about the specific symptoms and not ask, does your child have constipation or not? And then we have abdominal migraine. So with this is an episodic or recurrent attacks of abdominal pain. And sometimes they may have migraine associated features. And it's part of the migraine spectrum disorder. So with this, the children will present with very severe pain, usually in the midline or periumbilical area. It will last for a few hours to days. And when the child is within between episodes, the child is fine and well. And it will take a long time before the episode will come again. And then the child would have the abdominal pain. And when it comes, they may have nausea or vomiting or headache, and they may have photophobia. So they have the migraine-like symptoms associated with the abdominal pain. And as I said, all these are clinical diagnoses. So once you take a good detailed history, you examine the child, you look out for these migraine-like symptoms, you can make a diagnosis of abdominal migraine. And then we have the centrally mediated abdominal pain syndrome. And with this, the pain is continuous or nearly continuous. It doesn't stop. As soon as the child wakes up from bed, the pain continues, and it's through the whole day. And it's so significant that it can impact the child's daily functioning or activity. And with this, usually psychological and environmental factors amplify the symptoms. So the stress that the child goes through, and most of the time, it takes a toll on the mental health of these children, and this worsens the pain that the child has. It will interfere with their school, their activities, and even sometimes sleep. But when you examine, you take a detailed history, you find out that the child is growing well, examination findings are fine. But in this stage, you really need to take your time to exclude other organic causes before you can make this diagnosis. So why do we need to recognize a pattern? Remember that when it comes to disorders of gut-brain interaction, it is not, you're not making the diagnosis because you examined, you did the labs and everything was fine. So you are making the diagnosis. You're making the diagnosis because you found the symptoms, you found the signs, or you did the symptom actually fits the diagnosis, and that is why we are making the diagnosis of disorders of gut-brain interaction. So please, let's take note of this quote. It's not because you didn't find anything, but because the symptom fits that particular clinical diagnosis. So this is a little algorithm that we have at Kolebu Teaching Hospital that shows you how to go about investigating or managing a child with chronic abdominal pain. And Dr. Ankuma will take her time and go through these with us in the subsequent presentation. So my take-home message is chronic abdominal pain is common in children, and you need a detailed, structured clinical approach to help you distinguish between organic disorders from disorders of gut-brain interaction. And we should avoid diagnostic labeling of our patients without objective evidence. And remember, careful clinical assessment is the cornerstone to make a diagnosis. And when it comes to disorders of gut-brain interaction, it's very important that we know about them and we recognize them just as we would for organic disorders. So these are my references. I would want to acknowledge the PSG Gastroenterology Nutrition Subspecialty Group, my boss, Dr. Afar, and Dr. Mills. And I want to say a very big thank you for staying with me through the presentation. Thank you.
Thank you very, very much, Dr. Ananibim, for very comprehensive talk there that you've given us. The applause is already flowing. There was a comment in the chat just for laughs. I think
I just saw it, yes.
the Liverpool fans are not very
angry with me. I'm so sorry.
There's been a bit of gut-brain dysbiosis. Is that the word?
I think so, yes.
So thanks so much, Nanama. I think we have more clarity on this, but I'm sure there'll be questions which we will probably take later after we've had at least 3 of the talks, depending on how we do for time. People can type in the chat so they don't forget what their questions are when we get there. So Juliet is ready for us. She's already loading her slides. Thanks again, Dr. Ananibim. So, Dr. Juliet Kuma is a pediatrician at Komfo Anokye Teaching Hospital, and she's currently also a fellow in training in pediatric gastroenterology. So we're so excited to have you speak on the topic investigating and then management of chronic abdominal pain in children. You have the floor, Juliet. Thank you.
Yes, that's.
All right, thank you so much. And I'll be taking the second part of the presentation. My name once again is Dr. Juliet Ankuma, as already introduced. I'll be taking us through the investigation, diagnosis, and management of the child coming in with a chronic or a recurrent abdominal pain. So this is going to be our outline. We'll talk about investigating the child with chronic abdominal pain. We'll look at the general approach to managing a child with a chronic abdominal pain, and then the management of a child with an abdominal pain-related disorder of gut-brain interaction. So yes, abdominal pain is a very common presentation to our clinics, and sometimes investigating this child with abdominal pain can become very challenging. in the sense that on one hand, we want to avoid over-investigating the child, because as we have learned from the first presentation, most of these children have no organic cause of the abdominal pain. Majority of them have a functional abdominal pain. And on the other hand, also, we want to make sure that we do not miss any underlying organic disorder. So sometimes it becomes difficult knowing how far to go with investigating the child coming in with a chronic abdominal pain. And we all know that investigating a child also comes with a lot of cost. Aside the financial cost regarding labs, imaging, we know that doing all these investigations also even worsens parental anxiety, because sometimes it leads to a lot of incidental findings, and these incidental findings tend to cause more anxiety for the parents and for the child, and it tends to also shift our focus from the symptoms that the child is coming with, and sometimes we tend to look endlessly for an underlying disorder that we are not even sure what it is. So the dilemma of the clinician: when do I investigate a child coming with a chronic abdominal pain? And when do I just reassure without doing any investigations? This is what we are trying to unravel this afternoon with this presentation. So Dr. Nana Ama and Anibinfo already went through these red flag symptoms and signs. It's very crucial that for every child who presents to us with a chronic abdominal pain, we go through the history and examine carefully to be able to elicit these red flag symptoms and signs. Because the presence of these red flag symptoms and signs makes an organic disorder very likely. And in their absence, an organic disorder is not likely. So how do we approach investigating a child with a chronic abdominal pain? After going through our history and our examination, if there are no alarm features and the child fits the Room 5 criteria for a disease of gut-brain interaction, then we should be very confident in making the diagnosis of a functional abdominal pain or a disorder of gut-brain interaction, in which instance we wouldn't need to extensively investigate the child. Some basic investigations may be needed to just reassure the families and even ourselves as clinicians that the probability of an underlying organic disorder is minimal. However, if alarm features are present, as we already went through in the first presentation, then we need to pursue some targeted diagnostic tests, which may include laboratory tests, imaging, endoscopy, based on what we suspect from our history, our examination, to be the possible underlying cause of the child's chronic abdominal pain. So if a child comes with a chronic abdominal pain, we go through our history, go through our examination, but are unable to pick up any of the alarm features or the red flags that we spoke about, then we do not need to do extensive investigations, but some basic tests to rule out the common common organic disorders that we know of in our environments. So it's important to do a CBC, looking at whether the child has a microcytic hypochromic anemia. That would help us know whether we are dealing with a PUD, a peptic ulcer disease, or an inflammatory bowel disorder. If there is neutrophilia, neutrophilia may suggest an infection in the GIT or from any other organ, for instance, a urinary tract infection. If there is eosinophilia, then we may be thinking about any parasitic infection in the GIT, or the child is also coming with dysphagia or dinophagia, then the mind may also go to an eosinophilic esophagitis. We do an ESR. An ESR would help us know if there is any underlying condition that is causing chronic inflammation, for instance, an inflammatory bowel disease. Urinalysis help us know whether we are dealing with the UTI as the cause of the child's symptoms. Stool RE, looking out for any GI infection, looking out for cyst, any ova in the stool. Or sometimes it's important to also check for an occult blood. And in our environment, it will be important to also do an HB electrophoresis if the child's sickling status is unknown, to rule out a sickle cell disease. So while there are alarm features, aside from doing these basic tests that we spoke about, then based on what we suspect to be the underlying cause of the chronic abdominal pain from our history and our examination, we need to do some targeted tests. So in addition to the baseline labs, it will be important to do a metabolic screen, looking at the renal function test, liver function test. Important to also do a blood glucose, rule out a diabetes mellitus. And if our history and examination is pointing to an inflammatory bowel disease, for instance, let's say a patient comes in with persistent or chronic recurrent fever, persistent diarrhea, bloody stools, our minds may go to an inflammatory bowel disease. And in that instance, it will be important to do a fecal calprotectin, which is a very good marker of intestinal inflammation. If a child comes with a chronic abdominal pain with associated back pain, our minds may go to a pancreatitis, and for which we may need to do a serum amylase and lipase. If a child comes with symptoms and we think that the child may have a celiac disease, not so common in our environments, but the screening test to do will be a tissue transglutaminase IgA and the total IgA. So we come to imaging. Generally, imaging has a very low yield in the absence of red flags or alarm features. And the common one that we usually request is the abdominal ultrasound. So imaging, and especially our abdominal ultrasounds, should actually be guided by what we suspect to be the cause of the child's symptoms. So yes, it should help us answer a particular question. So we are not just going to send in a request for an abdominal ultrasound with a query, abdominal pain query cause. We would try to find out from our history and our examination what may possibly be the underlying cause of the child's pain, and then request the abdominal ultrasound. So abdominal ultrasound will help us pick up a gallstone, choledochal cyst, a renal calculi, an ovarian pathology, or any mass in the abdomen. Then we come to abdominal x-ray. Abdominal x-ray is rarely indicated in the child presenting with the chronic or recurrent abdominal pain. And a few instances, some clinicians have requested x-rays for constipation, but it's important for us to note that constipation, just like was discussed in the previous presentation, is a clinical diagnosis, and we do not need an x-ray to diagnose a child with constipation. Contrast studies, be it a swallow, meal, or follow-through, in some instances may be important in investigating a child with a chronic abdominal pain, but usually these are specialist-directed. It may be useful in investigating a child that we suspect may have a congenital malformation of the bowel or surgical adhesions or a malrotation that may have been missed. MRI, CT scan, rarely required in investigating a child with a chronic abdominal pain. And in IBD, a magnetic resonance enterography may be important in establishing the diagnosis. But again, this should be specialist directed. Next is endoscopy. So when do we request an endoscopy for a child coming in with a chronic abdominal pain? It's important for us to note that not every child coming in with a chronic abdominal pain needs an endoscopy. An endoscopy, in the absence of alarm features, is really not indicated. Endoscopy is usually warranted when we suspect the child may have an underlying mucosal abnormality of the GIT. And some common indications are abdominal pain with significant morbidity or with features of organic disease. For example, anemia, weight loss, vomiting, or fever. Or when the child is coming in with an unexplained anemia, and especially when this anemia is refractory to treatment, and we've not been able to ascertain any other possible cause of the anemia. And a child coming in with GIT bleeding, dysphagia or dinophagia, which may point to an esophagitis, whether it's noophilic or a reflux esophagitis, would also need an endoscopy. Also a child coming in with a chronic diarrhea, let's say a child comes in with a history of a chronic diarrhea, which is bloody with associated weight loss, that child needs an endoscopy to help us know whether it's an inflammatory bowel disease we are dealing with or not. So now we come to the management of a child presenting with a chronic abdominal pain. So management of a child coming in with a chronic abdominal pain depends on what we are able to ascertain as the cause of the child's abdominal pain. If after going through our history, our examination, our investigations, we find that there is an organic cause, underlying organic cause, then would have to treat whatever organic cause that we find. However, if we do not find any organic cause and we are able to make a diagnosis of a functional abdominal pain or a disorder of gut-brain interaction based on the Room 5 criteria, then we should be able to explain this to the parents, let them know that even though the child's pain is real, there is really no underlying organic disorder, and that's our goal of managing the child is not going to be eliminating the pain completely, but we are going to help the child, help her get back to her normal daily activities. Usually is when we are able to take our time to counsel the parents, let them understand what it is that we are dealing with, and let the child also understand that even though she's experiencing the pain, there is really no underlying organic disorder. Majority of them have been found to improve on adequate counseling and reassurance. Some psychological and behavioral therapies have also been found to be very useful in managing the child with a functional abdominal pain or a disorder of gut-brain interaction. Cognitive behavioral therapy, where the child is taught some coping skills to help her manage the pain better or deal with any negative thoughts regarding the pain. Then gut-directed hypnotherapy, where certain techniques are used to cause a deep relaxation, and this deep relaxation helps to quieten the gut nerves. So these are other what I spoke about are the psychotherapies that can be employed in managing the child with the chronic abdominal pain. It's important that we look for chronic constipation and manage adequately. As said in the previous presentation, majority of these children may have some constipation, and it's important that we manage them as well. It's important to also identify stresses that the child may have. Is the child having any issues at school? Is the child having any issues in the home? Any bullying? Is the child having any difficulty with his or her academics? If we are able to identify and address all these, it also improves the outcomes in these children. Pharmacological therapies usually have a limited role in managing the child with a chronic abdominal pain. Prokinetics, antispasmodics, fiber, probiotics are generally not effective. When do we consider referring a child with a chronic abdominal pain to the pediatric gastroenterologist? If the child has alarm features present, but we are not able to make a clear diagnosis as to what is the exact cause, then we may consider referring the child to the pediatric gastroenterologist. Or let's say a child comes in with persistent pain despite reassurance and behavioral therapy, then we need to refer this child for the gastroenterologist to also take a look. And if we suspect the child may have an organic pathology, but we are unable to put a finger on it, and the child is presenting with very distressing symptoms, that child may need to be referred to the pediatric gastroenterologist. Okay, so now we go through the management of the specific functional disorders as was discussed in the previous presentation. So if a child is coming, we suspect from our history and our examination that the child is coming in with a postprandial distress syndrome, which is one type of the functional dyspepsia. We know that majority of these children really do not respond to medications. There is actually very limited evidence for using medications in these children, as treatment is mainly supportive. But it's known that usually if we modify the diet of these children, giving smaller, lower fat meals, some of the children tend to improve on them. Cyproheptadine, prokinetics, there isn't much evidence for their use, but it's been used in some cases in literature with some improvements. And if the child is coming in with persistent vomiting and with associated weight loss, we may consider doing gastric emptying studies to ascertain what may be the cause. If the child is coming in with epigastric pain syndrome, in which case the child may have epigastric pain and heartburns, then we can give a trial of the PPI for about 4 to 8 weeks. As the child is on the PPI, we need to reassess to see if the child is improving on it. Otherwise, it's necessary to stop the PPI since there isn't any benefit. In some cases, we can also use an H2 receptor antagonist. In instances where the symptoms are refractory and under specialist use, amitriptyline can be considered. It's important for us to note that we do not need to test or treat for H. pylori simply because the child is presenting with symptoms and signs of dyspepsia. Okay, so for both postprandial distress syndrome and epigastric syndrome, the psychotherapies we spoke about usually also help these children. So in places where they have hypnotherapy and cognitive behavioral therapy, they have been found to be very helpful in managing these children. Peppermint oil, which is a natural antispasmodic, though there isn't much evidence for its use, has been also found to also be helpful. So if you are managing a child you suspect has a functional dyspepsia and this child is not improving on any of the medications or treatments you are given, then it's important that we reassess to look for any alarm features that we may have missed. In the presence of alarm features, then we may need to go in to do an endoscopy to be sure we are not missing any organic cause of the child's symptoms. We come to irritable bowel syndrome. Again, management of these children is mainly non-pharmacological, and the psychotherapies are also found to be helpful in managing a child with an irritable bowel syndrome. If the child is coming with an IBS with constipation, then we can also give some laxatives and see if it helps. If the child is having diarrhea, it's been found that majority of the children coming in with IBS and associated diarrhea have bile acid malabsorption, in which case we would need to give some bile acid sequestrants and see if it helps. Fiber has been tried also in literature in some cases, as well as probiotics, specifically the lactobacillus rhamnosus, and there has been some improvements in some children. However, there is very limited data, as already mentioned, for the use of any medication in children presenting with irritable bowel syndrome. It's important for us to note that antispasmodics, restrictive diets, surgery are generally not recommended in the child presenting with an irritable bowel syndrome. Okay, so now we come to an abdominal migraine, where the child will come in with repeated episodic stereotypic attacks of abdominal pain, and there are symptom-free periods of about a week to sometimes about a month. During the attacks, it's important that in between attacks, it's important that we are able to identify and reduce any triggers that we identify. Is a child coming in with attacks of these episodic pains because he's not sleeping well or missing meals? Is he having so much screen time, or is he experiencing a lot of stress? If you are able to identify these triggers and manage them appropriately, it helps to prevent subsequent attacks. Then during an attack, keeping the child in a quiet, dark room, allowing the child to get enough rest and sleep has been found to be helpful in aborting an attack. And simple analgesia like an NSAID is also very helpful during an attack of an abdominal migraine. If the child is coming in with frequent attacks, that is becoming disabling and affecting the child's school, affecting the child's daily activities, then the specialist may consider prophylaxis, in which case amitriptyline, topiramate, and some triptans may be considered. Okay, so coming to the child with a centrally mediated abdominal pain syndrome, previously known as the functional abdominal pain, not otherwise specified. As already discussed, as the general approach for a child coming in with a chronic abdominal pain, we need to establish a very good rapport with the parents and with the child, explain the diagnosis to them, let them know that even though the child is coming in with pain that is real, there is really no underlying organic cause. Deal with any psychosocial, any stresses that the child may be going through, and then institute psychotherapies where available. Cognitive behavioral therapy and gut-directed hypnotherapy have been found to be useful in these patients. And in some instances, neuromodulators like amitriptyline have also been found to be useful. Again, there isn't much evidence to support the use of medications in these children. Majority of these patients do very well with our counseling, our psychotherapy, and our follow-ups. And it's important to try and get one clinician to follow up this child so that subsequent reviews will be done by the same clinician. That helps to get better outcomes in managing these children. Okay, so now we come to talk briefly about H. pylori infection. And it's important for us to note that not every child coming in with a chronic abdominal pain requires us to test for H. pylori infection. If a child presents with an abdominal pain, a chronic abdominal pain, our focus should be on trying to find out what may be the underlying cause of this child's symptoms and not solely diagnosing H. pylori. Invasive and non-invasive tests for H. pylori are not indicated in a child coming with a functional abdominal pain. Okay, so who should be tested for H. pylori? So according to the NASBAN and ESPAGAN guidelines on H. pylori infection in children, only children with gastric or duodenal ulcers or erosions on endoscopy should be tested for H. pylori, as well as children with unexplained or refractory iron deficiency anemia after we have ruled out other possible causes. Or if the child is coming in with a chronic abdominal pain and this child has a first-degree relative with a gastric cancer, then we may need to do a test for H. pylori. And even in this case, a non-invasive testing is recommended. So in testing for H. pylori, endoscopy with biopsies remains the gold standard. So when doing an endoscopy, we take biopsies, and afterwards, confirmation of H. pylori infection will be by either a positive culture and or molecular test, or we find H. pylori gastritis on histopathology with a positive rapid urease test. So a rapid urease test alone is not enough to confirm H. pylori infection. Okay, so continuing with the how to test for H. pylori. During endoscopy, 6 biopsies need to be taken from the antrum and also from the body of the stomach and sent for culture, molecular testing, as well as histopathology. So doing the stool antigen test or the urea breath test, though helpful in checking whether H. pylori has been eradicated following treatment, is not recommended in the initial diagnosis of H. pylori infection. And the antibody test for H. pylori, as well as the molecular test on saliva or blood and stool culture or stool molecular testing are also not recommended. So talking about eradicating H. pylori, if a child goes through an endoscopy, gets biopsies done, and gets H. pylori confirmed through the positive culture or molecular test or on histopathology together with the positive rapid urease test, then we can proceed to treating this child. In centers where it's possible to do a susceptibility testing, it's crucial to test whether there is sensitivity to clarithromycin or not before initiating treatment. If the organism is found to be clarithromycin susceptible, then we can go ahead to do the triple therapy with the PPI, amoxicillin, and clarithromycin. However, if there is resistance to clarithromycin, or we do not know whether or not there is resistance because we could not check for clarithromycin sensitivity, then we need to put the child on the quadruple therapy. That is bismuth, PPI, amoxicillin, and metronidazole. So how do we confirm eradication? So after treating a child we diagnose to have H. pylori infection, we need to also check for to be sure that this child's treatment was successful. And it's important to do this more than 4 weeks after the antibiotics have been completed and more than 2 weeks after PPIs have been stopped, because if the child is still on antibiotics and the PPIs, then they may suppress the growth of the H. pylori even when they are present. So you may get a false positive, a false negative. So the preferred test for confirming eradication of H. pylori is the 13-carbon urea breath test and the monoclonal stool antigen test. Serology is not recommended because the positive is an antibody test, and a positive antibody test for H. pylori does not help us distinguish between a present or a past infection. So key takeaways from this presentation are that if a child comes in with a chronic abdominal pain, it's important that we go through a thorough history and a physical examination to be able to ascertain what the underlying cause of the child's abdominal pain may be, whether organic or functional. And our investigation should be guided by our clinical findings and not just performed routinely. It's important for us to avoid unnecessary investigations in order to reduce cost, anxiety, and incidental findings. And we should be able to confidently diagnose a child who presents with a functional abdominal pain or a disorder of gut-brain interaction after going through our history, our examination. If the child fits the Room 5 criteria, we should be able to confidently make the diagnosis of a disorder of gut-brain interaction and manage appropriately. And we know that management should be holistic. It should involve us counseling and educating the parents and child about the diagnosis, and also helping to restore the child to her activities of daily living. And finally, diagnostic testing for H. pylori, whether invasive or non-invasive, is not indicated in the child coming in with a functional abdominal pain. So I'd want to acknowledge the PSG Gastroenterology and Nutrition Subspecialty Group, Dr. Nicholas Ejay and Dr. Taiba Afa. These are my references. Thank you so much.
Thanks so much, Dr. Juliet Kuma. I think you really done an extensive job for us, looking at investigation, diagnosis, and management of a child with chronic abdominal pain. Even before your session was over, someone's question in the chat box was already answered. So I think all of us are getting more clarity on this very broad subject matter. And we've been told that functional dyspepsia doesn't equate to H. pylori testing or treatment. I'm sure there'll be more questions as we go along. Please feel free to type your questions in the chat box, and I would humbly ask our speakers to type in responses, if possible, for some of the questions that are put in the chat box, just so we have less to do when we get to our Q&A session. So we're moving on to another very exciting segment of the program. We have our talk by our one and only Dr. Victor Etri on the role of the pediatric surgeon in chronic abdominal pain and its management. So whilst he's loading his slides, I think Dr. Etri doesn't really need much introduction, but we will still say something. So this is Dr. Victor Kobi, Echi. He is a consultant pediatric surgeon for Kolebu Teaching Hospital, and he also renders service to Princess Marie Louise Children's Hospital, Accra, and also Cape Coast Teaching Hospital. He's an adjunct lecturer in pediatric surgery for the University of Cape Coast School of Medical Sciences. His interests are in pediatric colorectal pathologies and pediatric GI endoscopies. No wonder he's giving this talk. He's also an associate pediatrician for those of us in Kolebu. So, Dr. Victor Echi, you're most welcome, and we are ready for you. Thank you.
Thank you very much, Abna. Thank you also to PSG and everyone, the gastroenterology and nutritional team, for inviting me to be part of them. Actually, I'm a member of PSG, so it's okay to do this. And I actually had in mind to have just 5 slides, but I ended up with, I think, 10. So you indulge me just a little bit. So I'm going to look at chronic abdominal pain and the surgical perspective. Well, we have all been given a very good meal of chronic abdominal pain or recurrent abdominal pain in children by Dr. Anani Bimfo and Dr. Ankuma. So I don't have much to say by way of that subject, except that, in the past, before pediatric gastroenterologists surfaced, the primary referral for chronic abdominal pain, recurrent abdominal pain of any type whatsoever was primarily referred to the surgeons. And I believe this was because through my entire life in medical school, and I'm sure a lot of us also going through medical school, seldom had any talk from pediatricians or physicians on abdominal pain. Surgeons were the ones doing all the lectures in abdominal pain, acute abdomen, peptic ulcer disease, etc., etc. So I think that by and large, a lot of people have come to associate surgeons with abdominal pain or abdominal pain with surgeons must manage. I believe the other reason also may be that because we get into the abdomen, probably we see all the organs there, the ones you can see the naked eye and the ones that you have to see under the microscope. And so it is thought that, once they know what is in there, they definitely will know the diseases that are in there. And so let us send it to them. But this afternoon, we have had a very eye-opening talk, and I believe that going forward, things will change. And I think that right in 4th MB, Dr. Afar and her cohorts must start teaching about abdominal pain. Before the acute abdomen. In fact, I think they should even take the acute abdomen so that we can start having a change in mindset as far as abdominal pain is concerned, because many of the children have been subjected to all manner of things. So we generally manage the organic, I say generally because, we've been told that most of it, 90%, 90 to 95% is inorganic. And so, so we manage the organic courses that fall on our table. And we know that organic courses usually have red flags that will help us to identify these ones. And so there's a need to then have an appropriate evaluation before surgical referral. So I'm sure going forward, I'm going to start seeing less referrals to the surgeons for these challenging chronic abdominal pains. Now, I have some memorable cases and I just want to share with us all. And long ago, not long after I'd finished my specialty training in pediatric surgery. This young lady came, about 9-year-old, and she had been seen in various places, etc., etc. Eventually landed in pediatric surgery, and she presented with these episodes of screaming and writhing in pain, and I mean the whole ward wouldn't be quiet. Investigations were done. Eventually, we found a very clear and, in fact, a rare presentation. She had a leiomyoma in the head of pancreas. And once that surgery was done, the child, her pain stopped magically. Then there was this other one that I recently saw in Cape Coast, who also had this acute episodes where she had had this pain for a long time. She would be there seemingly okay, and then she would just start screaming and crying and then hold her tummy. And after some episodes, she would stay, quiet. She had imaging done. You saw a cystic swelling in the tail of the pancreas. And so the radiologist then did a percutaneous drainage, considering a pancreatic pseudocyst as the pathology. After that, it didn't resolve. She still had these episodes. So one of my visits to Cape Coast, she had been admitted for me. I saw her, and we looked at the CT scan, and this mass was still there, small though. And so we went in to remove it. And histopathology said it was a choriostoma. It was gastric tissue in the tail of the pancreas. And thereafter, the child no longer had these episodes. Then I had this picture up there which shows the smiley umbilicus, who came to me after she had also been seen by numerous doctors. And her issue was that she had had repair of ventral hernia in childhood, early childhood, by a pediatric surgeon. Investigations had been done, CT scan, thinking of adhesions, abdominal x-ray, thinking of adhesions, etc. Nothing really. She was not vomiting. Nothing was, except that there was pain in the periumbilical region. So the decision I made was to explore the wound and see what, and I found out that she had her repair done with nylon. And so I took out the nylon and then re-repaired the fascia. I took the nylon out and then re-repaired the fascia with absorbable sutures and converted her smiley abdominal wound to something better. And she sent me a very beautiful thank you card, which I have in my office, and I'm grateful I was able to help her. And then there was this patient also. I'm narrating these because that is what comes to us, and sometimes we're able to help, other times you're unable to help. So there was this patient I saw in one of my clinics at PML. Mother came, had been seen somewhere, referred as umbilical hernia. And after talking to the woman, we realized that no, this is not likely due to the umbilical hernia, but she insisted. Once someone has seen and referred that it's umbilical hernia, go see the surgeon who will fix you and all your problems will be over. They hold on to it, even if the diagnosis is not umbilical hernia. So she came insisting, and so we told her, look, we can get you evaluated and later come for the hernia when everything said, but no, she wouldn't have any of it. So we fixed the umbilical hernia because cosmetically it needed fixing. And few weeks after she came back, she had abdominal pain. We told you so. So we had to manage her otherwise. Then I had this patient who was referred to me that another place also had abdominal pain, and an appendix had been taken out and the pain was persistent, came to me, and I was able to manage non-surgically diagnose functional pain, and found my way out, and father was very grateful to that. I had this colleague who was always calling me abdominal pain, the daughter. One day he came, there was what looked like an acute abdomen, vomiting, etc. We diagnosed acute appendicitis. We went in, we took her appendix out. Appendix didn't look much of a culprit, but anyway, that's what we went in for. After the surgery, I was there. Father calls me again. My child has abdominal pains. Okay, bring her in. And then did an endoscopy, found that she had gastritis, significant, treated, and he hasn't called me. I'm still waiting whether the call will come in again. Then we had this child also, the bottom picture, showing a lot of scarification on the abdomen. Certainly has been having abdominal pain over a long period of time. The other surgeons had done their therapy by giving him some what do you call it? Modulation therapy. Once you inflict other source of pain on the abdomen, the inherent one will disappear. So has scarifications and apparently had a huge spleen, which was taken out, and his pain went away. So these cases come to tell me that, yes, we have been at the end of receiving abdominal pain, chronic abdominal pain. Some of them we're able to help. Some of them, they are not on our table. And so we need to find the proper exit for them. Right. So some of the common reasons that these patients are sent to us for umbilical hernia. So in the midst of investigating the abdominal pain, a scan is done, diagnose umbilical hernia, go and see the surgeon. Pain that is related to meal, say gastritis, or there is peptic ulcer disease. H. pylori has been done. It is positive. Say you have an ulcer. And I'm happy for Dr. Nkuma's presentation, though there are some nitty-gritty points that we need to iron out. That H. pylori infection is not always equal to peptic ulcer. And so we need to be circumspect in our tagging of patients with that and managing them in that regard. Then also the constipation-related abdominal pain that is referred to us, where patients are present with constipation, associated abdominal pain. They've been managed and constipation is persisting, then they are sent over to us. I'm happy Dr. Afar is around now, and so she's taking some of the burden off us, but they still come to us. And the ones that especially are impacted, they say, go and see the surgeon. He's the one whose finger can take the stool out. But I'm happy we all have 10 fingers. And so the physician can take the stool out as well as the surgeon. Fortunately for us, we now realize that Coca-Cola can disimpact even the very hard ones that are like stones. And so we are tending to employ Coca-Cola enema, not oral. Coca-Cola enema to disimpact some of these tools where maybe the anus is so small that, so it's helping. Or when they have hedge fronts and our fingers can't reach that ball of stool that is high up. So these ones come in. One thing I can also say, just a bit on constipation before I go on, is that a lot of times we give, in our management of constipation, we do all the dietary modification, etc. We give laxatives, but sometimes the laxative we give are small doses that do nothing. And then sometimes they are for very short periods. And so these patients end up having refractory constipation, and that doesn't help. So we need to probably up our game in that regard. Then comes mesenteric adenitis, which is a differential for appendicitis and many other things. And just this morning, we got a referral from Police Hospital, mesenteric adenitis / acute appendicitis. I called the doctor and asked, is the patient guardian? He says no. I said, okay, anyway, you bring the patient, we'll manage. We will not send to Dr. Afar yet, but we'll manage and then see what goes on. Then we also get these patients that someone does an x-ray, sees some dilated bowel loop, and the child has passed some stool somewhat. So it doesn't fit intestinal obstruction because the child has passed through, but then there's a dilated loop on the X-ray. So it says, okay, partial intestinal obstruction, sent to the surgeon. So these are the type of cases that we are receiving, and we're doing our best to manage them. But are there really real reasons? I mean, a common real reason for referral to the surgeons? Are there any pathologies that are so common that the surgeon must come in here to manage chronic abdominal pain or recurrent abdominal pain? If you say common reasons, then real reasons, there really aren't many, but I want us to go through a few things that we encounter. So the role of the surgeon will come in where an organic cause has been identified. So gastroenterologist first, and then the surgeon comes in next. Now, so I picked a slide from Dr. Anani Benfo's presentation. And so we see this page and we see that what really has the surgeon got to do and the gastrointestinal part. And we've seen out of the whole list, probably just the malrotation, duplications, and tumor, which is the last three in there. And then we look at the hepatobiliary aspect, and we see that the surgeon has to do with gallbladder calculi, appendicitis, and cholelithasis, cholecystitis, okay, some pseudocysts and choledochal cysts are there. Genitourinary calculi, yes, will come in there. Ovarian cysts will come in there. PUJ obstruction will come in there. But the rest really may not. Okay, hematocorpus will come in there, but the rest may not. Then the other metabolic and musculoskeletal will come in probably sparingly. Sorry for that. So what do we really see on our side here, and we have to do something about? So the ones that we see that we can't do something about are umbilical hernias, if they are having recurrent obstructions, appendicitis, pseudo or partial intestinal obstructions, be they adhesions or stenosis, malrotation or megavolvulus Hirschsprung's disease. Then you can come in the urologic aspects, and tumors and intra-abdominal cysts. So where we come in now. So a bit on the umbilical hernia. So umbilical hernia has frequently been accused and implicated, even though wrongly, because like I said earlier on, child presents with abdominal pain, ultrasound is done, even in the presence of an obvious umbilical hernia. We allow the sonographer to be the one to diagnose umbilical hernia and say, go and see the surgeon. Your child's pain is due to umbilical hernia, and some of the parents will not move until you have fixed that hernia for them. But the symptoms and signs of its guilt are often clear and unmistakable. That is to say, if the reason for the pain is due to an umbilical hernia, the symptoms and signs will be so clear. And so one of the symptoms would be an established presence of umbilical defects. I agree some of them may be a few, but very, very few. About 1% may be obscure, especially in the children that are obese, and so you may not be able to palpate the defect, but most of them, you see an obvious defect. And the pain the children will complain of will occur at a time when there is a content in the hernia and it is irreducible and painful. So when mothers or parents come to us with children with umbilical hernia and they say that is the source of the pain, we ask them, have you ever observed a time where at the time of pain, hernia is painful, irreducible, and probably had to go to, and in a lot of situations, they will say no. In a few instances, yes, they will tell you that yes, whenever he has pain, the umbilicus is swollen and it's hard, and then they have to wait a while, give paracetamol, and then the pain relief occurs soon as the swelling also disappears. So it's quite clear. And where the pain, the swelling has persisted for some time, still painful, then later vomiting may ensue because of the obstruction that occurs. So when umbilical hernia is the culprit, it is quite easy to make that diagnosis, careful history, and in a lot of, in all the situations, once you repair the hernia, the pain goes away. Fortunately, a good number of obstructed umbilical hernia will come to us in the acute or abdominal pain situation. And so we are not seeing them so many, but these are one of the things we encounter. Then famous appendicitis, which has been another one that implicated for recurrent or chronic abdominal pain. Now, and sometimes it is because what happens is a child may have had an episode of acute appendicitis, often clinically acute appendicitis is clinically diagnosed and is very easy. Abdominal pain, central, and then migrates to the right iliac fossa, and there may be nausea or vomiting, a low-grade pyrexia, and all that. So once you examine the abdomen, you find tenderness and guide iliac fossa, and so it's fairly easy to diagnose in the acute state. We know that until the appendix comes out, a lot of times it will just go on to either it may resolve spontaneous, especially the catarrh type, or go on to become complicated, abscess, peritonitis, etc. But the problem is that there's a lot of misdiagnosis because pharmacies may be the first point of call that parents will go to when the child has abdominal pain. And so someone, prescribe, not prescribes, but they buy all kinds of medications over the counter. The pain goes away. If it's catarrh, the appendicitis resolves, and then only stays resolved for now to appear later. And so you can have that repeated episodes. Sometimes also they may go to hospital, all right, but they may have taken something along the way, or they may end up getting some analgesia being given. And so pain disappears, the diagnosis is not made, and so probably managed as mesenteric adenitis. So they go home only to have another pain another time, and may go through that cycle again. So misdiagnosis. Then the other aspect also is where there are red herrings. That is, child has appendicitis, all right, but mother forces history out of the child. Tell me, when you went to school, you played soccer. Yes, and someone kicked you. Yes, and I can imagine when I lived in one of the rural areas, the child narrating, and I'm in school now, Kofi, yeah, bobo, not in and I bore me, so once they have that history, they go to the hospital, and mother goes telling the doctor that, oh, he had trauma. And so that is why the pain. And so someone doesn't touch the abdomen, doesn't make that diagnosis, managed as, abdominal trauma, and then it goes on like that. Then we also have the armchair or over the phone consultation. The child goes to the clinic, all right, but clinician sits in his chair comfortably, take history, touch the upper abdomen, 1, 2, 3. Okay, all right. So take this medication, some PPI for the road, some paracetamol for the road, and then the child goes away. So that acute episode is not diagnosed, and the child keeps coming in with these recurrent appendicitis. But once sometimes they go through that kind of role and all the misdiagnosis, eventually they end up with an appropriate examination and investigation and get the appendix taken out and get lasting relief from that. Then we come to the intestinal obstructions, and with that we have the acute obstructions, which are often easy to diagnose, and they come from a good clinical assessment. Once you do a plain radiograph, usually gives it away so easily. Dilated loops of bowel, fluid levels, etc. There are telltale signs, and the diagnosis is made, the surgeon sees, and then management is done appropriately. Seldom does one need contrast radiographs in the acute setting. But in the situations of partial obstructions, you know, and when we talk about partial obstruction, we are looking at those children with the bowel stenosis, or those who have the adhesions, or those who may have the malrotation. Sometimes will undergo valvular, sometimes will trace back to normal, or the Hirschsprung's disease. They sometimes can be challenging. So, and the symptoms may be subtle and present sometimes like a chronic abdominal pain, you know. But there again, the red flags are there, and there may be associated vomiting or weight gain, poor weight gain, or there may be constipation. Sometimes a good examination will show that there's some visible peristalsis or a dilated bowel loop on the abdomen. And where one is not sure, one can employ a contrast radiograph, or sometimes an advanced imaging, maybe a CT, depending on what one is looking out for. That will be beneficial. And so in those instances, yes, we have a very important role. Go in, handle it, and then the pain goes away right away. So now, partial obstructions that will mimic or that will present as chronic abdominal pain, and it calls for good history examination and appropriate investigation to make that diagnosis. Then there comes the urologic obstructions. Sorry, before, okay, I think I've made my comment on the constipation, so that is okay. Yes, then we come to the urologic obstructions, and for that aspect, I must say that in recent times, we have been picking a lot of them in the neonatal and infancy, and so and that is really good, because when I was in training, I was a house officer, and in training, we're seeing these urological obstructions very late. Childhood and late childhood, we had to remove a lot of kidneys and, you know, a whole lot of, but now with prenatal sonography and for anatomy scans being done, a good number are being picked up prenatally, and that is helping in the management, salvaging kidneys and preventing the chronic kidney disease that may be associated with delayed presentation. However, we still have some coming as late presentations, and they may present as those with recurrent abdominal pain. When they have these obstructions, because of the stasis, they get recurrent UTIs, and so they present to a clinician frequently. You do urine RECS positive, you are treating UTI. There is this adage that if you treat a boy child is allowed to, in fact, any man is allowed to have only one UTI in all his life. If he gets two, then you need to investigate for an obstructive uropathy, obstruction somewhere there. So let's have that in mind. The girl child, can have a few because of the short urethra, but then again, the girl child also deserves to have other anatomical aberrations excluded in the course of having a UTI. So they present with recurrent UTIs, and sometimes the red flags are there: flank or suprapubic mass, or flank or suprapubic pain. And in these instances where these red flags are there, imaging is very useful, and sonography will be the first line, and other contrast imaging may come in later when they are needed. And the common obstructions that we see, posterior uteral valve and hydronephrosis due to pelvic ureteric junction obstructions. I think posterior uteral valve is, if you take the obstruction, neonatal obstructions and bowel obstructions away, I think it ranks number 2 in our emergency list for pediatric surgery. So anytime you have abdominal pain and suprapubic mass in an infant or a child, don't forget that urologic obstructions can be a culprit. Right. Then come the others, tumors and intra-abdominal cysts. They are not so common as causes of abdominal recurrent or chronic abdominal pain, but Usually they are identified on imaging when people are being evaluated. So like one of the presenters said, that sometimes incidental findings. So sometimes these are noticed on incidental findings on the investigation, but a few or most of them come to us obvious masses that come to us, and then we manage. So where they are found incidentally or where they come in as obvious masses, sonography, yes, may have been done before coming to us, but it's the first line. Then CT scans or MRI may help us narrow down whether it's a choledochal cyst or whatever other problem that it may be. And the common ones that we see, not in any order, I think we see probably more ovarian cysts than any others. Multicystic kidney disease more than any others. Ovarian cysts may be the next. And then these other problems also come to us, which we manage because they may have presented as chronic abdominal pain. So in conclusion, recurrent abdominal pain, as we know, is not, or chronic abdominal pain is not uncommon in the pediatric population. Real surgical causes exist, though they are not so common as how abdominal pain is common. So if you take 100 children with abdominal pain, you're probably looking at just maybe 10% having surgical causes or less than that. So appropriate clinical evaluation, investigation are very important, and they will help, put the diagnosis, by us and not cause us to run all over the place. So I need to know that extensive or traumatic or invasive investigations are rarely indicated, in the child with the recurrent abdominal pain, as has been said. And so we need to be circumspect in the things that we do. And if imaging is required, ultrasonography is the most useful first line, So thank you very much for hearing me. And as has been said, we'll make room for questions when all of us have spoken. Thank you very much. Abna, over to you.
Thank you so much, Dr. Tree. I really enjoyed your talk. I think Dr. Tree has tied it all in nicely, giving us the surgeon's perspective, what they're able to do, the differentials that we would consider consulting the pediatric surgeon to help us handle. And today we've learned that Coca-Cola enema, not taken orally, can help to disimpact stools when a child has constipation. And also we should be wary of parents forcing history out of children. So those were some points that I took from his presentation. Thank you once again, Dr. Tree. As we said earlier, please do type in your questions in the chat box. Those that can be answered prior to the Q&A session, they will be. Also note that in the chat box, we have the forms that we need to fill if we want CPD points. The CPD points have been obtained for doctors. They'll work on those for nurses and other allied health professionals. The evaluation form has also been put up. So please let's fill that so that we can get feedback on the session and how much we've enjoyed it so far. So thanks once again to Dr. Tree. So we move on at this point. And then someone else also asked for the slides. Note that we are streaming on YouTube, so you can always revisit the webinar once again on YouTube, and you get the whole thing to listen to. So we've come to a very, very exciting part of the talk. In fact, the whole webinar is exciting, but this part is even more because we're getting to hear from the parents' perspective. I mean, we do all we can on our side, but do we ever think about what the families go through when we are doing all our fancy investigations and giving all our treatments? So to share with us, we have Mr. Fred Sapong, who will give us a brief talk on the psychosocial and economic impact on the family with a child who has recurrent or chronic abdominal pain. Mr. Fred Osei-Sapong. I'm not sure if you have slides or you're just going to speak, but I'll briefly introduce you just before you begin. So Mr. Fred Osei-Sapong is a husband, proud father of 3, 1 boy and 2 girls, and a resident of Amasaman in the Greater Accra region. He's been married for 8 years and lives with his family. Professionally, Fred works with an international organization where he contributes to initiatives that improve the well-being of communities. But beyond his career, he's so passionate about family life, sports, and lifelong learning. And as we said today, he's not speaking in a professional capacity, but as a parent, which is a very important perspective that we need to hear. Sharing with us his experience with his daughter's unexplained abdominal pain. So Fred is on the line. We're ready to hear from you. Thank you.
Abdominal, for that wonderful introduction. Yeah, so let me say a very good morning, good afternoon, good evening to colleagues on the call from wherever you are listening to me from. Yeah, so I was just going to give just an oral presentation, but I mean, previous speakers did PowerPoint, so I had to quickly put my thoughts together. So with your permission, I'll probably go ahead and make my presentation.
Sure.
I believe my screen is visible.
Yes, please.
Okay, so I proceed. Yeah, so before I proceed, just to say that our journey in trying to find answers to an unexplained abdominal pain that our daughter went through is something that I had actually wanted to erase from memory. We've been through pain, we've been through trauma, and it's something that we really didn't want to talk about. But for the purposes of education, for the purposes of probably helping another parent or giving more information to health workers, I decided to take this up and share our story. Yeah, so where did it start from? Somewhere October last year, our 6-year-old daughter began experiencing some pains in the stomach. We had thought that stomach pains is just a minor thing that she was presenting with. So usually we would just say, oh, just take water, try and pull, you should be fine. But then around December, we realized the thing was getting more serious. So something that we thought was a minor issue eventually graduated and became severe and episodic. So when it started, you could have like 1 episode in 3-4 days time, another episode. But then with time, the frequency of the episodes increased, and then the pain also became more severe. Interestingly, as of those times, she had no temperature, no bloating, she wasn't nauseous. Everything about her was extremely fine. Just that when she is going through the episode, you could tell that the little girl was in extreme pain. Pain that we sometimes, as a parent, when you sit by her and you see her go through it, you also feel the pain. So initially, we visited some hospitals, some treatments were given, but none of it gave any relief or so whatsoever. And by December, you could clearly tell that the episodes had affected her well-being. It has affected her quality of life, everything about the girl, the whole family, as well as other friends and relatives. People got to know about the ordeal, so they kept calling, trying to find out, visiting. And when they visit and they experience how the little girl is going through pain, you could clearly tell that some of them actually shed tears. And this was quite traumatizing, so to speak. So our journey took us to 8 hospitals. I said 7 hospitals because there was one hospital that basically did not do anything. They just took history of what we've been through and concluded that if the facilities we've already been to couldn't do anything about it, then they are sorry, we should go elsewhere. So I decided to take them off. Indeed, I wanted to give a chronology of how events unfolded, but if I did that, I'm not sure we will end this call today. So I decided to just give a summary of what we've been through as a family. Yeah, so between January to March 2026, we've been to about 7 hospitals. And within these 7 hospitals, multiple conditions were considered and also investigated. Most of you are medical officers, doctors, nurses, so you understand that investigation goes with laboratory examination and a few others. So we did quite a lot of laboratory tests, a lot of diagnostics, so many things, but unfortunately, none of them provided the answers the medical officers were seeking, as well as the solutions the family sought. Yeah, so along the line, the episodes started increasing. Earlier on, I mentioned that she was experiencing the pain maybe once every 3 days, once every 4 days. Now it became 2 to 3 episodes in a day. And when the episode starts, at the peak of it, the little girl could be in pain and cry for as long as 1 hour. At the peak of the episodes, she was experiencing between 5 to 6 painful episodes in a day. And this was very, very traumatizing. So, watching your daughter, watching your child go through such very disturbing pain, unexplained, you really don't know what was happening to her. We were even thinking of what other underlying conditions or other organs within the body that could be going through some, I don't know the right medical term to use, but we were very worried because we thought there could be something more happening in the stomach beyond the pains. We were only kind of seeing what was being manifested outside, but we knew nothing of what was going on within the stomach. So we felt very, very helpless. And anytime a hospital, a medical officer prescribed a medical test, a laboratory test for us, we had hope because we thought this would identify the cause of what our daughter was going through, but only to go for the results, go for interpretation, and you realize that it's the same old story. Nothing organic has been identified. So, sleep patterns, work, school, our entire family routine was disrupted. The little girl wasn't going to school. My wife and I were totally absent from work. We couldn't just do anything. We have 3 kids, as was earlier on mentioned, but we stayed practically in the hospital with the child of concern and left the other 2 in the house, in the mercy of God, because we were so much worried and so concerned about what she was going through. And anytime I made an attempt to just leave the hospital and try and do a bit of work, on my way out of the hospital, you begin hearing echoes of a loud cries. And whenever that happened, the only sensible way you could do as a father was just to turn back and make your way back to the hospital. And in most of those times, by the time I get to the hospital, my daughter will be in pain. It's been very, very traumatizing for myself, my wife, my family, and close relatives. So, like I said, so many conditions were suspected and investigated. Previous speakers mentioned H. pylori test. Indeed, almost every hospital we went to did H. pylori test. Even when we told them that she had already done it 2-3 days ago, they will still do it because they probably trust their diagnosis, or they are unsure whether where we went, they did the right thing. So they will still insist and get it done. Constipation was suspected, gas and bloating, paraumbilical hernia. In fact, now I've gotten used to how to pronounce the medical terms. because I've spent months, weeks in hospitals. So gastric ulcer, appendicitis, pancreatitis, bowel obstruction, so many conditions were suspected and investigated. Eventually, some imaging reports showed that there was some obstruction in the stomach, and immediately my daughter was pushed into theater and surgery was performed. In fact, the 3 to 4 hours that we waited in front of the theater for our daughter was the most challenging of all the trauma we went through. In fact, that 4 hours was more like a day, an entire day for us, as we waited patiently in front of the theater for our daughter. But lo and behold, and through the grace of God, she came out and then started recuperating. When we thought following the surgery, everything has ended, 2 days after, the pain came back. And what was more worrying was the fact that our daughter opened the mouth and clearly told us that the pain that brought us to the hospital had returned. As of that time, they had just done a surgery. 2 days after surgery, the wound was trying to heal, and our daughter was back in pain. And when this pain comes, she is stretching, bending down, trying to lie down, So in doing that, the place where the surgery took place got infected, and they had to hold her and then try and express whatever it was from where the surgery was performed. And in all this, at some point, as a father, as a man, I just couldn't stand it. I had to just walk out of the hospital, go and sit in my car. And what happened in the car, I think I would prefer to keep to myself. Soon after, the surgical team informed us that they suspected gallstones. So they wanted to take our girl back to the theater. This was within basically some 10 days after the initial surgery. So at this point, my wife and I decided that, look, we do not think we are ready for this. So we wanted to explore other options. So this took us to some specialists, some consultants who did further assessment, including laboratory, endoscopy, colonoscopy, several other imaging tests. Indeed, some of the test results had to be sent outside the country because they were not immediately, there were no labs in the country that could immediately investigate or undertake such labs, so to speak. Yeah, so after all these were done, there was still no organic cause of the condition, and our daughter continued to suffer and go through intense pain. Let me pause for a moment and then just try and, talk about the various medications we were given. So from facility 1, as in the first hospital, to somewhere 6th, 7th hospital, we've taken Maalox, we've taken Nexium, amoxicillin, Lactoluz, Movicol, Pariet, clarithromycin, omeprazole, morphine, alkaline citrate salt, sucralfate. In fact, several medications. I think I even left some of them out. Along the line, we performed some additional labs, and one of the labs showed that her liver function test, the liver enzymes had elevated about 10-fold, and that was very, very concerning for us as parents. We actually did not know what was going on, and we were so scared that our daughter may not be able to survive another medication. So anytime we spoke with our friends, our family who were in the health sector or in the health field, those were our concerns. Those were the issues we spoke about, but they kept reassuring us to keep trusting in the medical system. In fact, there were even some recommendations from other friends and relatives that we should begin to seek spiritual attention. But we believe that God was going to answer our prayers through the doctors, through the nurses, and then the medical system in which we live. So along the line, we met our consultant, and then she finally told us that, look, I've gone through everything. I've observed that there is no organic cause for what your daughter is going through, and that I'm going to manage her for functional abdominal pain. What I've come to understand that is now called disorders of the gut-brain interaction. Such a very big word. Yeah, so some medication was given in addition to some dietary adjustments. And I am happy to say that within 4 days of going through the new therapy, as in the medication and dietary adjustments, we began to see some, reduction in the pain episodes as well as the frequency. And that was quite very, very relieving to see that our daughter was going through just 1 or 2 episodes in a day, 1 episode in a day. Then we went a whole day without an episode. Then the episodes were now coming like once in a week. And I'm happy to state on this call that the last time she had an episode was on the 3rd of May. And with this, I can sincerely say that our daughter became a child again. In fact, the little girl was traumatized. She couldn't play, she couldn't learn, she couldn't do anything. And we also dreaded hearing just 2, 3 words from her. Daddy, the pain is coming. But I'm happy to say that these words are no longer the common words in our household. But then, going through all this, what came at a cost, the consultation fees, the various investigations we did, the repeated investigations, the several medications that we had to buy. You buy this medication today, you take it for 3 or 4 days, and you are told that based on this, you need to change. Stop using this, go for the other one. But then we were not really bothered about the financing. Our objective was to ensure that our daughter was out of that trauma. Our daughter had come out of the pain. The constant, continuous travel between hospitals, anytime the pain started, we had to rush her to the hospital. And that also presented major risk, moving up and down highways, trying to reach the hospital so the doctors could actually appreciate the kind of pain we were talking about. In fact, some of the doctors indicated that anytime the pain came, we should take a phone and take a video of her. But of course, this little girl also had her own concerns. Anytime she's crying and you pick a phone to video her, she will get very upset, even as she's in deep pain. So it was quite difficult for us to just pick a phone and then cover her. So we needed to present her in that state to the medical facilities, the medical officers, so they could appreciate and understand better the kind of pain she was going through. And indeed, myself, my wife, who is also on the call, couldn't go to work at all. And that also really affected our economic life. But then the actual cost of what we went through was beyond the bills. It was far beyond the monies that we had to spend. The extreme pain and trauma that our child had to go through. In fact, that pain actually radiated to all of us in the house. You see her crying, and the little ones will also start crying. The mom, siblings, everyone in the house, you see them shedding tears because of what our daughter was going through. Beyond that, the repeated blood tests. In fact, at some point, I wish I could just stand in and take the blood for her, but of course, that wasn't possible. A girl of 6.5 years old, sometimes they were drawing about 5 different tubes, 6 different tubes from this little girl, and none of them was done without excessive crying. She will cry and cry and cry, but we knew that that was the only way they could get to the bottom of what was actually happening. So family anxiety was at its peak, highly elevated, as we continue to stay around our child who was going through this pain. And of course, as I indicated earlier, There was also that burden of friends and families continuously telling us to seek spiritual attention. But of course, we trusted that God was going to answer our prayers through the medical system. And in doing so, we actually paid little attention to our two other kids because we felt this one needed more attention. And of course, anytime that some labs were done, there was hope, but at the end of the day, you realize that nothing really came out of it. So we've learned some lessons as parents, which probably will be our very last slide. It's important, very important, that we give more attention to some of these psychosocial impacts that such prolonged, unexplained conditions could bring to parents. You go to some facilities and you realize that they've seen it all. So what are you talking about? And you could really tell that people, I don't want to use the word heartless, but you could tell that because people have seen it time and again, they are not so much concerned about what you are so much worried about. And I think as a medical system, we should be able to show empathy, even when we know nothing organic is happening to the child or to the patient. And for other parents on the call, you may be a medical doctor, you may be a nurse, you may be whatever. I think it's important that you seek early medical intervention. When our episode started, we thought it was something normal, something trivial, until somewhere December when we felt the condition actually needed medical attention. We realized that our child had to endure several medical pricks, several invasive processes where blood had to be drawn, even when some laboratory tests or same tests had been done in a trusted laboratory. We still had to redo it. And all these were quite traumatizing for our little girl. And going through a number of hospitals, we also came to the conclusion that some physicians or specialties were trying to kind of manage the situation just by themselves without opening up to other specialties to come in. In fact, there were instances where we had to actually tell a team in a particular hospital that please talk to your other colleagues. Please talk to not just your other colleagues in this hospital, but seek consult from other hospitals. Probably somebody has come across something like this before, but anytime we did, it appeared they trusted in what in their own capacities, and they wanted to do it on their own. And I think all these kind of delayed appropriate management for our child. So we also think that it's good to persist. If we had given up and followed the spiritual line, I'm not sure we will be here today. So we continue to trust in the system, though there were challenges, there were difficulties, but we hoped that eventually we will find the answers. And it's also important that any family going through this should find money, because it's not cheap. I don't want to talk about the total cost of the ordeal we went through, but it's not cheap. You really need to find money before you can survive and bring hope to your child, to yourself, to any member of your family who may be going through a similar situation. So I believe when we were seeking for care, we went through a number of hospitals. So I believe some of them may be on the call. So I would like to use this opportunity to say a very big thank you to all of them for the care they provided. You may not know my voice, but when I mention the name of my child, you will know, but I'm not going to do that. So if you've ever extended such care, support to somebody going through what I just explained, then we are here appreciating the support you extended. Thank you very much, and over to you, Dr. Abdominal.
Thank you so much, Mr. Osei Sapo. We appreciate you and your wife for sharing your story with us. We are privileged to have you on the call. I think Daddy has given us a comprehensive list of differential diagnoses of chronic abdominal pain. Indeed, he's gone through a detailed drug history, past medical history, history of presenting complaints, all of that, and social and family history. So much to take away from his talk. So thank you once again. So we invite you to type your questions in the chat box. You can raise your hand and, if it's possible, yes, to unmute and talk. I've seen a question from Prof. Goka. I'm not sure if she was on at the time that I think, yes, I don't think a question has been answered, and I think it's for Juliet. So from Prof, am I correct to deduce from Dr. Ankuma's presentation that by and large, H. pylori testing should be left to the pediatric gastroenterologist? I think Juliet or Nanama can answer for us.
Okay, so I think I've answered the question in the chat box. If we suspect that the child that is presenting with the chronic abdominal pain has an organic cause of abdominal pain and a possible H. pylori infection, then we would need to refer that child to the pediatric gastroenterologist so that an endoscopy will be done and gastric biopsies are taken to confirm the H. pylori infection. And also that would, doing an endoscopy would help us know whether the child has gastric ulcers or duodenal ulcers. Thank you.
Thank you, Juliet. Yes, I wasn't sure if Prof. Goka saw it, so thank you for answering again. And then another question, functional abdominal pain. Is it a diagnosis of exclusion? At which point do you investigate? Where do you draw the line? I think this has also been touched on, but maybe you can just summarize for us. Is it a diagnosis of exclusion? I think that's a question to either Juliet or Nanama.
Okay, so let me take that. We are saying that it shouldn't be a diagnosis of exclusion. However, if a child presents with a chronic abdominal pain, you go through a thorough history, do your examination, and you are able to pick up the red flags, signs and symptoms we spoke about, then that would increase the probability of an organic disorder. If we go through the Room 5 criteria and the child fits that criteria, then we should be confident in making a diagnosis of a disorder of gut-brain interaction. So now the guideline says we should move away from excluding an organic disorder. Rather, we should be confident in making a positive diagnosis of a disorder of a gut-brain interaction if the child from history and our examination findings fits that criteria. I'm not sure if I've answered the question. Thank you.
Thank you, Juliet. Thank you. There's a comment that was shared with me privately, and I think this is a question other clinicians may have. Maybe a few pointers. I know Nanama did mention this, but when sometimes a clinician tells a parent that they think that it's functional, forgive our use of the old term, in that it's not organic, sometimes it's almost like you're not believed. How do you go? What are the good pointers you can give to the family so that they can understand what you're trying to explain, that it may not always be an organic cause for this abdominal pain? So either of our speakers, Juliet or Nanama. Thank you. Dr. Ananibin for Dr. Nkuma, when you're counseling the parents, what are good points to make to sort of carry them along when you're trying to explain that there isn't a structural cause, there isn't an organic cause for the abdominal pain?
Hello, Dr. Abnatechi. I think Dr. Anna Nibinfo wanted to take the question, but she says she's finding it hard unmuting. So if you can help unmute her.
Hello, Abna, can I take it? Dr. Afar here. Oh, okay.
All right, I just found a number, but you can go ahead. Okay, let me see if I can unmute her. Okay, Dr. Afar, please go ahead. For some reason I can't seem to.
Okay, I hope I'm not going to deviate. So the question is, even when a physician has told a parent that this is a gut-brain disorder, the parent is not taking it, what must you do? Actually, at that point, I personally think that you are playing the role of the subspecialist. If you do your basic invest, because although the current Room 5 criteria suggests that it is no more a diagnosis of exclusion, you will do the basic thing, full blood count, ESR, urinalysis. Definitely you would need to do those things to rule out the minor issues. Once you have done that, you are not capable of doing endoscopy, or even if you have seen any red flags in that regard, I would suggest that you refer the child. You can tell the parent that at this point, you may need other interventions that are beyond the scope of a general pediatrician. However, this is what I think, but sometimes the child will come and it is not a functional problem. So for me, if you get to that point, you can call me. I have actually consulted with a lot of pediatrics who and I and them have not known each other in person. But then once you get to that domain, please let the patient go, because Fred and his family are not pleased with what they have been through, and I share in their pain. There is the other question in relation to H. pylori, whether H. pylori is now in the domain of the gastroenterologist. Far from it. We are not saying that don't do H. pylori, but then H. pylori is overrated, including herbalists. I'm saying this with confidence. I have pictures. If I had done the presentation, I would have shown evidence of H. pylori associated medications. I mean, 6 medications that a herbalist gave in the name of H. pylori. We are not saying don't investigate H. pylori, but then H. pylori is a minor problem in recurrent abdominal pain in children. Stool H. pylori done test, it's okay. We don't have a problem about it. But then if you manage H. pylori based on positive H. pylori test and it's not working, please refer the child. And also, Juliet, I'll take this opportunity to clear the H. pylori issue. Juliet also mentioned the fact that if you are suspecting an organic cause, you would have to do endoscopy. Then we would have to do rapid urease test, which we always do. Once we are in there, I always would want to do my H. pylori test. And sometimes, even if the H. pylori test is negative, Dr. Etri would actually confirm this action of mine. And I see the GI, stomach, gastric evidence of H. pylori picture, which I usually commonly would say in theater, and H. pylori, I bear H. pylori. I definitely would manage. And also, Juliet also said it's not only rapid urease test. There's a publication we did a couple of years back, Afar Etri et al., on children who have come into endoscopy with abdominal pain and related issues. And we compared the rapid urease test yield and the histology test yield, and they were apart. So for us in a resource limited country, those of us who do endoscopies, once you do your rapid urease test and it is positive, please go ahead and manage. However, just like the presenter said, after 1 month of therapy, when you have finished antibiotics, when you have finished PPI, then you would repeat to make sure that there is clearance of the infection by doing the stool H. pylori test. Thank you. I'll end here for now. I have other comments, but then I'll give the comments once questions have been answered. Thank you.
Thank you, Dr. Fa. Nanama, sorry, you couldn't unmute, but I'm not sure if you have anything else you wanted to add.
I think Dr. Fa has addressed most of the things, but I just wanted to say that once at the beginning you counsel the parents on your initial diagnosis of a disorder of gut-brain interaction, you take your time and explain the pathophysiology with them. You get them on board, the parent on board, especially to understand what the child's condition is. The pain is real. We are not saying the pain does not exist, or we are saying that the pain is in the head of the child, or the child is making the pain up. The pain is real, but the pain is not due to a structural problem. This, in a way, would reassure the parents, and then they work with you when it comes with the management, and you are able to work hand in hand with the parents. Because when it comes with these disorders, you need the parents to be on the same page with you, so that as you are managing, you are getting feedback, they are coming up for follow-up, and then you know how to continue the management. So once you explain to them very well and they're able to be on the same page with you, then it makes the management and follow-up a bit easy for you as the clinician. Thank you very much.
Thank you, Nanama. Thank you, Nana. So a comment in the chat box. With those of us in the rural communities, this is from Lewis, I think. After a child has tested for H. pylori for recurrent abdominal pain, we go ahead and treat if there is no pediatric gastroenterologist. So that's someone sharing their, should I say, management. After this lecture, perhaps we will have other options to explore for these children. I think Monica also shared her experience similar to what Fred described for us. In the end, well, she said she did a scan and it was a tiny hernia. She got her pastor to pray. And since December last year, the pain hasn't come again. So that's Monica's experience. I don't know if there are any other questions or comments. If it's not in the chat, please feel free to raise your hand or unmute and speak.
Rabina, I would have some comments.
All right, then Dr. Fa, please go ahead. Since we're about 2.5 hours. Yes, please go ahead.
Okay, all right, okay. So comments here from me. Yes, to the presenters, I'm very happy with the fellows' presentation. I am so proud of you both. Thank you very much. In fact, I sat here and I am so happy that, okay, Dr. Fa is not the only one around. I have support and I have able support. For those of you who don't know, now Ghana College is doing fellowship in pediatric gastroenterology. Our curriculum has been approved, and these are our first official fellows. Then to the surgeon, Dr. Tree, thank you very much for letting us know that it is not everything that you need to bring on to the surgeon. I must say that actually the referral to the surgical discipline for chronic abdominal pain has reduced for the past 10 years. When I came, it was so bad, just like the jaundice. But then abdominal pain to the surgeons has sort of reduced. I'm happy about that. And then one of the presenters also spoke about rectal examination, which is very important. But then you usually will defer rectal examination for the subsequent visit, not for the first visit. Usually the first visit, I would not recommend you to include rectal examination. However, if it is a patient Who has known you? This is my personal experience. The patient might have known me through their pediatrician. The investigations they have done was through their pediatrician. So it is now time for them to come to me. So they already know me. And for that time, I'm happy to do a rectal examination. And if I know this is a patient I'm going to see in theater to do endoscopy, I usually forget about doing rectal examination, especially in older children, because in theater, I would have a go to examine the area as I please. Then also, as pediatricians, when we have children with chronic recurrent abdominal pain, always think of child abuse, either physical, neglect, or sexual abuse. Sometimes in your interactions, look at the parent-patient interaction. It might give you a clue. So don't forget about child abuse. And then also abdominal ultrasound or investigations that doctors do again and again and again, and they'll find incidental findings and they don't even know what to do with them. The first one is the mesenteric adenitis. They are given gazillion doses of antibiotics. I don't know whether to sterilize them, and then they will come up with all sorts of things. Sometimes a patient was diagnosed with a single ovary and they went round and round, and the problem is the single ovary or horseshoe kidney. That's the kidney function test is completely, there is absolutely nothing wrong with the child. But then because these are incidental findings, it skews everybody's attention to that. And then you don't even know what to do with this patient. Sometimes we need to think about, what am I going to get from this investigation I am going to do? Then comes the endoscopy. The endoscopy, people know how to do endoscopy, but not everybody is conversant with pediatric endoscopy. And what usually I will ask, people will say, okay, you have abdominal pain, go and do endoscopy. And then they will go to town, to market, to do endoscopy elsewhere. They'll bring the results to me to manage. Then I ask, whoever does endoscopy should know how to follow up, how to manage the patient. Right now that you have brought this patient to me, that I didn't see the inside, that I didn't take biopsies for additional things, not just the H. pylori, whoever sent them they are thinking of. It's usually very difficult for me, I must say. And Dr. Etri will tell you that I've always been complaining of this, because the biopsies we take is not only for H. pylori. H. pylori biopsy, rapid urease test is done right there, and we clear it. But there are other histologic diagnoses that are of benefit to us that we are able to manage, and you rob us of that management and bring me a piece of paper with a patient who is still with abdominal pain to manage. I think you are not being fair to me. Then also umbilical hernia. Dr. Shri has cleared about umbilical hernia. Sometimes the umbilical hernia is diagnosed by ultrasound, and the parent will come and tell you that that is the pain. The surgeons have done theirs, so you will fix it. And also, my comment in relation to the Coca-Cola. Please, doctors, the Coca-Cola enema is maybe a pilot that is being successful by the department, pediatric surgery unit in Kolebu. It's not been published. We don't know how much Coca-Cola is given. We don't know how usually it's done. And for me, I wouldn't do it, and I will not recommend you to do it without consulting them or without referring them, the patient, to them, because I have no experience, and I don't think that you need to advise the patient to go and give Coca-Cola enema. And then my last comment is to Mr. Fred Sapon. Thank you very much for accepting this presentation. You have opened up to talk about your pain. We understand. And I know that some of the people on the call, even the doctors, some of them are parents themselves, and they know how it feels. And so thank you very much. And thank you for giving me the opportunity, Pediatric Society, and Abna, you take over. Thank you.
All right, thank you so much, Dr. Afar. I think you rounded up nicely for us. For those of us who don't know Dr. Afar on this call, She's one of our pediatric gastroenterologists, very passionate about this topic of abdominal pain. So we are very grateful to you for your contributions. It's 5:45 almost. I'll just read one last question in the chat. What's the pediatric community take on management of H. pylori infection from a positive antibody test, that is via blood test? I think any of our speakers can take that. Juliet, Nanama, or Dr. Fa. I think it's been spoken about, but can you kindly re-echo?
It is not recommended. I don't want to use a derogatory term because it is of no significant yield. If you are a pediatrician and you want to diagnose H. pylori, I would say that do the stool antigen test. Thank you.
Thank you so much. Wow, we've had a good time this afternoon, this evening. We've had a mix of medical, surgical, patient perspective on this topic of chronic abdominal pain. We are so grateful to all our speakers. We hope you filled in the evaluation form. We really need this for feedback and also for those who want CPD. We've learned a lot today. It's not just about investigations. It always comes back to a good history, a good history. And remember that often non-organic causes are the majority for chronic abdominal pain. We're thankful to all our speakers. Again, Dr. Anani Bimfo, Dr. Juliet Ankuma, Dr. Victor Itri, Mr. Fred Osei-Sapon, very grateful to you for your time, sharing your experience and your knowledge with us. This has been the PSG Gastroenterology and Nutrition Sub-Specialty Group. So I'll end with we started with a prayer. I'll end with a short prayer. And if there are any comments, from our co-chair, Dr. Nyako, are you still on the call? You can give us some final closing remarks. Yes, please.
Okay, thank you very much, Abna. And I just want to say a big thank you to our presenters. I mean, you were fantastic. And then and thank you to all the team members behind the scenes. Thank you for your support. And I hope that after this, we'll be ready to do more. And thank you all for those who joined. We hope that it will impact your practice and we'll be able to manage our children with abdominal pain better. Thank you very much. God bless you all. Bye.
Thank you. Thank you to everyone who stayed to the end. We have over 200 participants still on the call. So we end with a prayer in the name of the Father and of the Son and of the Holy Spirit. We thank you so much for a very educative session that we've had. We've learned a lot about this topic. We pray that as we go out as clinicians and as caregivers, we will do our best for our children. Thank you. In Jesus' name we prayed. Amen. And goodbye to everybody. Our session is over. Have a great rest of the week.
Thank you, Abna, for an excellent moderation. God bless you.
God bless you too. Thank you, Dr. Itri.
Thank you.
Thank you very much. Bye-bye.
Thank you.